Welcome back. In this session, we're going to be looking at respiration under stress. And you'll recall that right at the beginning, we pointed out that the resting oxygen consumption, for example, of the lung, increases enormously when we go to exercise. The normal oxygen consumption of the order of 300 mils per minute can easily go up tenfold to 3 liters a minute, 5, or even in an elite athlete, 6 liters a minute, something like that. So the lung is greatly stressed by the situation of exercise. In addition, the lung represents one of the largest surface areas, if you like, of the epithelium to the environment. You remember I pointed out that the area of the blood-gas barrier is the order of 50 to 100 square meters. The area of the skin is only 2 square meters. So in a sense, the lung is vulnerable to environmental situations. So here are the subjects we're going to be dealing with, and let's start with exercise. Now, as I mentioned, during exercise, the oxygen consumption increases dramatically. And here we have a plot of the oxygen consumption on this axis, V.02, oxygen consumption in liters per minute, against the work rate. And this can be measured on a cycloergometer or perhaps a treadmill. And what you find is that as you increase the work rate, the oxygen consumption increases linearly until you get to a point where the oxygen consumption levels off and does not rise anymore. And that's known as the VO2 max. And you'll often hear athletes talking about their VO2 max. I've got a VO2 max of 60 mils per minute per kilo or something like that. And it's a good measure of an athlete's fitness and ability to exercise. So what's happening above the VO2 max here? Well, any increase in work rate there has to come about not through oxygen utilizing mechanisms, but by anaerobic glycolysis. Now let's look at what happens to ventilation as we increase either the work rate or the oxygen consumption. Oxygen consumption shown here. And here's the ventilation increasing linearly with oxygen consumption. It's very remarkable that it does that, by the way. Remember when we talked about the control of ventilation, I pointed out that I am very ignorant about all the causes of the increase in ventilation on exercise. But as you can see, there's a linear increase in ventilation with oxygen consumption here. But at a certain level of exercise, the ventilation tends to increase more rapidly. And sometimes there's a break point there, and it's sometimes called the anaerobic threshold, although that's a controversial term, and a more politically acceptable term now is the ventilation threshold. But it turns out that at this threshold, the concentration of lactate in the blood, shown by the broken line here, tends to increase fairly rapidly, and the lactate then stimulates the peripheral chemoreceptors, increasing ventilation even more. The increased hydrogen ion concentration stimulates particularly the carotid body, and the ventilation increases more. And sometimes you can pick out this break in the plot of ventilation against oxygen consumption. It's interesting because it is a measure of the fitness of a person. If you're put in bed for a couple of weeks because you've broken your leg or whatever it is, then when you get out of bed, you find, if you exercise, that this anaerobic threshold, so-called, will occur at a relatively low oxygen consumption. But with increased training, the anaerobic threshold occurs later, and it's a measure then of fitness. Now, what about blood flow? Well, cardiac output, shown here as Q dot, also increases linearly with exercise, but you can see that the increase in pulmonary blood flow or increase in cardiac output is much less than the increase in ventilation. And there are a couple of ways of looking at that. One is that, of course, it's much easier to move air than to move blood. But it's also interesting if we look at the Fick equation for oxygen consumption on the blood flow side and an analogous equation on the ventilation side. Here's the Fick equation that you'll recall. The oxygen consumption is equal to the cardiac output times the difference between the oxygen concentration in arterial blood and mixed venous blood. Okay, that V should really have a bar over the top to indicate mixed venous. And what happens is that Q does not increase as much as ventilation when we write the analogous equation for ventilation. The analogous equation would be oxygen consumption equals ventilation rather than cardiac output against the inspired fractional concentration of oxygen minus the expired fractional concentration. This is a similar kind of equation. So why the difference? Well, the difference is because the arterial venous difference for oxygen concentration, the difference between the arterial oxygen concentration in the arterial blood and the mixed venous blood, that increases on exercise, and therefore Q does not rise so much. However, and that's because the body accepts a lower oxygen concentration in mixed venous blood. However, this does not occur on the ventilation side. The body will not accept a reduction in the expired oxygen fraction, which is equivalent, means that the alveolar PO2 and therefore the arterial PO2 is maintained during exercise. The body does not allow those to fall, and therefore the ventilation has to increase substantially more than oxygen consumption. Okay, so during exercise a number of other things change, and I'll just mention them briefly. I mentioned the increase in cardiac output, and that's associated with an increase in the pressures in the pulmonary circulation. Both the pulmonary artery pressure rises, of course, because you've got to move more blood flow through the pulmonary circulation. The pulmonary venous pressure also increases because the left ventricle needs an increased filling pressure to increase its output. That increased pressure in the pulmonary circulation means that the capillaries are exposed to increased pressure. There is recruitment and distension of the capillaries. Pulmonary vascular resistance falls. The diffusing capacity of the lung increases for two reasons. One is that the area of the blood-gas barrier increases with recruitment and distension of the capillaries, and also the volume of blood in the pulmonary capillaries increases. In terms of blood gas transport, the oxygen dissociation curve is shifted when we come to peripheral muscles. There's a rightward shift caused by the increase in PCO2, hydrogen ion concentration, and temperature in exercising muscle, and that reduces the oxygen affinity for hemoglobin, which allows the blood to unload oxygen more efficiently in the periphery. Centrally, when the blood moves away from the hot muscles, the temperature falls a bit, and therefore the opposite events occur in the lung. In the muscle, there is an increase in the number of open capillaries because the blood flow increases. The throttles at the level of the arterioles in the systemic circulation open up, and the vascular resistance of this systemic vascular resistance falls a lot because, in spite of the increase in blood flow, the mean arterial pressure rises very little, so there's a big reduction in systemic vascular resistance. I say that the arterial pressure falls. It does that during dynamic exercise, such as running, which is what we've been talking about. But if you do static exercise like weightlifting, the arterial pressure increases. So a large number of changes occur in the presence of exercise, and we'll now go on to the next topic, which is high altitude. And incidentally, I might just point out that each of these four topics I'm talking about are quite large, and I could easily spend a whole lecture talking about each one, but of course we don't have time to do that, and so what we're doing is moving fairly rapidly through these topics. Now, of course, the important thing about high altitude is that the barometric pressure decreases with altitude. And here's a plot here showing the decrease in barometric pressure here, 760 degrees at sea level, and as we go to increasing altitudes, the barometric pressure falls. Here's Denver, the mile-high city. Here's Pikes Peak, the site of a very important physiological expedition 100 years ago, by the way. People live as high as a little over 5,000 up to nearly 6,000 meters. And Mount Everest has a barometric pressure of about 250 and therefore a very low inspired PO2. And here are the inspired PO2 values here. And of course, they're obtained by taking the barometric pressure, subtracting the 47 millimeters of mercury for water vapor pressure, and multiplying by the oxygen concentration of 20.9%. That gives you the inspired PO2. Incidentally, the oxygen concentration is constant throughout the atmosphere up to the level of Mount Everest and well beyond that. So we don't need to bother about changes in the oxygen concentration of the air. Now, a number of important changes take place when lowlanders go to high altitude. A very good example of adaptation to a stress, the stress of the hypoxia of high altitude. And one of the most important of those is hyperventilation. And let me show you an equation, a use of the alveolar gas equation, how that can be used to look at the importance of hyperventilation at extreme altitude. So let's look at somebody on the summit. We can calculate the alveolar PO2 from the alveolar gas equation. The inspired PO2 is 43, as we said. Suppose he maintains his normal ventilation, so his PCO2 is 40. The respiratory exchange ratio may be 0.8 at rest. So that is 43 minus 50 gives us minus 7 millimeters of mercury. Well, of course, that's ridiculous. There's no way we can be anything like that. So what can we do about it? Well, the only thing we can do is change the PCO2. We can't change the inspired PO2. We can't change the respiratory exchange ratio, determined by the metabolism of the tissues. The only thing we can do is change the PCO2, reduce that by hyperventilation. Suppose we hyperventilate fivefold, increase our ventilation fivefold, then we can reduce the PCO2 to say 40, and then we get 43 minus 10 is 33 millimeters of mercury. You may say, well, that doesn't sound like a great alveolar PO2 value. No, it's not, but it's just sufficient to maintain life on the summit of Mount Everest. And a few people can climb Mount Everest without supplementary oxygen. We're going to be learning more about that actually in the last lecture. So that's hyperventilation, a very, very important feature of acclimatization. The hyperventilation, of course, brought about by stimulation of the peripheral chemoreceptors by the low level of oxygen in the arterial blood. And it's interesting that if you go to high altitude, say in a day, you just drive up to high altitude, then the ventilation will increase. At the end of that day, the ventilation will be increased. But the increase in ventilation will then cause an increase in pH in the arterial blood, okay? Because you're going to reduce your PCO2, you're going to have a respiratory alkalosis. And in the same way, it's going to cause an increase in pH in the cerebral spinal fluid. And you remember we said that the CSF pH is critical in determining the level of ventilation. So immediately when you go to high altitude, you've got these two brakes or inhibiting factors on the increase in ventilation, the increase in pH in both the blood and the CSF. But after a short period at high altitude, maybe a day or two, the pH of the CSF tends to return towards normal. And after a couple of days, and that's because of movement of bicarbonate out of the CSF by the choroid plexus, and by the same token, the pH of the blood tends to return towards normal, and that's because of the action of the kidney excreting bicarbonate, the metabolic compensation. And so those brakes, those inhibiting factors on ventilation decrease, and ventilation increases further. So there's an initial rise when you go to high altitude, and then a further rise over the next few days as a result of the removal of these brakes on the ventilation. So that's ventilation at high altitude, by far the most important feature of acclimatization. There's another feature, though, that I want to just mention, and that is the polycythemia, the increase in red cell concentration that occurs at high altitude. In fact, I'm sure that if you ask a high school teacher what is the most important thing that happens at high altitude, most people will say an increase in the number of red cells. We don't put as much emphasis on that now as we did, and I'll tell you why in a moment. But let me show you what happens to people who live permanently at an altitude of 4,600 meters. That's about 15,000 feet or something like that. There are people in the Andes who live at this altitude, and they've been extensively studied. And it turns out that the polycythemia has increased their hemoglobin concentration from the normal value of about 15 grams per deciliter to 19.8. Very big increase. Now they have a very low arterial PO2, only 45 against ours at sea level, around about 100. Therefore, their arterial oxygen saturation, of course, is reduced. But because the hemoglobin concentration is so high, the oxygen concentration of the arterial blood can be as high as 22.4 mils per deciliter, which actually exceeds that of ourselves at sea level. So you can see the power of polycythemia in these people who live permanently at high altitude. Now, the reason why we don't put so much emphasis on it, one of the reasons is that if we're talking about people going to high altitude for a week or two, something like that, that's not enough time for the red cell concentration to increase. The red cell concentration increases because of the influence of the hypoxia on the kidney. The kidney releases erythropoietin, and the erythropoietin stimulates the bone marrow and to release more red cells. So that's the mechanism. But that's something that takes some time. In fact, it takes several weeks for the polycythemia response to level out. So although it's important in people who are living at high altitude, it's not so important for lowlanders. There's another important thing about the polycythemia, and that is that it increases the viscosity of the blood, and it makes it more difficult for the blood to unload oxygen at the periphery, in the peripheral tissues. And a very interesting study was done by a colleague of mine a few years ago when he went down to Peru, and he studied some of the people there who had been living there, and they were born there, living there, had very high hemoglobin concentrations, and he removed blood and waited 2 or 3 weeks until the blood volume returned to normal, but the concentration of red cells, of course, was reduced. And what he found was that in some of these people, their exercise capacity increased. So it appeared that the very high concentrations of red blood cells, high concentrations of hemoglobin in some of these people who live permanently at high altitude are disadvantageous. And you know, the evolutionary pressure for the erythropoietin mechanism that wasn't developed at high altitude. It was developed at sea level to replace blood which is lost through trauma or whatever. And the mechanism probably wasn't developed at high altitude. And although we don't have time to go into it, I can tell you that that people who live in Tibet do not have high levels of polycythemia, and we believe that is an adaptation, but we don't really have time to go into that. Let's just look at what happens to the PO2 of the oxygen cascade from the inspired gas to the mixed venous blood. Here it's drawn for sea level. Here it's drawn for these people who are living at 4,600 meters. And the carry-home message is that because of the increase in ventilation and the increase in red cell concentration, the PO2 differences in the mixed venous blood are relatively small. Now let's look at some of the other features of acclimatization. There's a shift of the oxygen dissociation curve. It tends to shift to the right at moderate altitudes, but at extreme altitudes it shifts to the left because of the the respiratory alkalosis, and we'll be talking about that a little bit more in the final session. There's an increased concentration of capillaries in muscles. That's not so much because of more capillaries, it's because the muscle fibers get smaller at high altitude and gives a higher concentration. And there are also changes in oxidative enzymes in the cells. So a number of things happen at high altitude. Now I'd like to mention one other thing at high altitude, and that is the fact that a number of deleterious changes take place, and one of them is the increase in pulmonary artery pressure. Now, the increase in pulmonary artery pressure, hypoxic pulmonary vasoconstriction, you remember we talked about that in the session on blood flow, and I pointed out that probably the most important evolutionary pressure for that mechanism are the changes that occur at the time of birth, when the vascular resistance of the newborn lung has to decrease very rapidly so the lung can take over the business of gas exchange. But hypoxic pulmonary vasoconstriction occurs at all ages, and it can be a real nuisance at high altitude. At high altitude, the pulmonary vascular resistance increases, pulmonary artery pressure increases, and there's no clear advantage in that at all. In fact, there is a serious disadvantage in some people, and the reason is shown here. It turns out that in some people, the hypoxic pulmonary vasoconstriction is uneven. Now, the reason for that probably is that in the adult, the distribution of vascular smooth muscle is patchy, uneven, because it undergoes involution after birth, and it's patchy in the adult. And what we've shown here in this little diagram is some capillaries which are downstream of the constricted arterioles, but some capillaries do not have arteriole constriction in front of them, upstream. And so these capillaries are exposed to the high pulmonary artery pressure. These capillaries are not. The pressure here is reduced because of the constriction. But these capillaries are exposed to the high pressure, and it's been shown experimentally when you expose pulmonary capillaries to high pressure, you get ultrastructural changes in the walls. You can see by electron microscopy, and these capillaries leak plasma and red cells, and you develop what's called high altitude pulmonary edema, and that's a serious illness that occurs in some people at high altitude, and incidentally the treatment is to bring them down as quickly as possible. So that's an example of a deleterious effect of going to high altitude. Now let me spend some time talking about diving, and that's a very big topic. I mention it partly because I'm sure there are some scuba divers out there who probably know a lot of this, but it's increasingly used commercially, diving to deep depths, and a number of interesting physiological stresses are associated with diving, and I'm just going to go through them in this list here. First of all, we should talk about decompression sickness, and any scuba divers out there will know all about this, and most people know about it anyway. Decompression sickness has to do with the fact that when you go down into the water, the pressure increases rapidly. Of course, the pressure when you dive increases much more rapidly than the pressure decreases when you go to high altitude. For every 10 meters of descent, the pressure increases by 1 atmosphere. So you can very quickly get to very high pressures if you go down to 10, 20, 30 meters of depth. Now what happens is when you go down, the nitrogen, which is normally a fairly inert gas, is dissolved in the tissues, particularly in fat in the body. It happens to have a relatively high solubility in fat, and that in itself is not deleterious. There's no problem with having the nitrogen dissolve in the tissues. The problem arises when the diver comes up again, because the nitrogen then comes out of solution, forms bubbles, because the partial pressure of nitrogen outside the diver is falling, forms bubbles, and these bubbles can obstruct blood flow and cause pain near joints, which are called the bends, but can also do much more serious things like cause problems with the central nervous system. Even coma sometimes can be caused by the bubbles of decompression sickness. So it's a serious problem in people who dive and come up to deep depths and come up rapidly. Now, how do you treat decompression? Well, decompression sickness. Well, the best way of treating it is to take the subject to a high pressure chamber. And many facilities have these. Hospitals have a hyperbaric chamber. Put the subject in the chamber, increase the pressure, and usually magically there's an improvement in the symptoms and the signs of decompression sickness, because what you're doing is compressing the bubbles back, and the problems largely disappear. Don't always completely disappear, but often the patient will say, oh, that's marvelous, I don't have any pain anymore. So that's the treatment of decompression sickness. The prevention is by ascending slowly. And again, scuba divers will know all about this. There are tables that tell you, depending on how long you've been, at what depth you've been, how rapidly you can come to the surface. And if you've been deep enough, then you have to come up in a series of stages. You come up a certain distance, you stay there for a period, you come up another distance, and you stay there. And that allows the nitrogen to be eliminated gradually. Incidentally, it's now believed that almost everybody who comes up from a dive develops some bubbles, and the important thing is to prevent them from becoming too large. So that's the prevention of decompression sickness. Incidentally, these tables have been developed through a mixture of calculations and also empirical data, and they keep changing slightly all the time, but they're very well known to people who do a lot of diving. Now, if you're a professional diver, and there are many people now who are used, for example, by the offshore oil industry for fixing valves and things at depth. If you're a professional diver, you'll often use a helium-oxygen mixture for diving. And the advantage of that is that the helium is a much less soluble gas and is much less likely to cause bends. And another reason why it's useful is that it greatly reduces the work of breathing. You remember when I was talking about airway resistance, we made the point that when you go to depth and the density of the gas increases, the resistance to breathing increases tremendously. And that occurs during diving, and divers can develop CO2 retention because they're not breathing hard enough. But if they breathe helium, this reduces the density of the gas and makes it much easier to move, and so the resistance, the airway resistance, the resistance to breathing is greatly reduced, and that's very valuable. A slightly odd consequence of helium breathing, helium-oxygen breathing, or heliox as it's called, is that people, if they've got a microphone down on their where they're working, which they usually have, they sound like Donald Duck. The sound has changed because of the low density of the gas in the larynx or whatever. But it's possible using electronic devices to change that and make it sound more like Mickey Mouse or someone like that. Saturation diving is an interesting topic, and we'll just mention it. Saturation diving is used again by professional divers who have to work on something, an oil valve or whatever it is, deep below the surface. And instead of coming up every day and having this long period of decompressing, coming up in stages, what they elect to do is to enter a chamber, and that chamber maintains the same pressure as they are at the depths that they're working, or very, very close to it. And that chamber is brought up and put on the deck of the tender, and the divers will spend the day watching television or whatever it is, and then the following day when they've got to go down again, the chamber will go down to the appropriate depth. They open the chamber, they'll go out and do the work. So they actually spend a number of days at high pressure, and that doesn't do them any particular harm. Of course, at the end of that period, then they have to decompress. They've got an awful lot of nitrogen or whatever it is on board, and that will take some time for them to return to sea level pressures. Let's say a word or two about inert gas narcosis, and again, any scuba diver will know about this. We normally think of nitrogen as an inert gas. It's just a vehicle for oxygen, mainly is what we think of it. But it turns out that if you go to high pressures, below say 50 feet or so, below that, then the nitrogen tends to affect the central nervous system. And it's a bit like having a martini or two. People tend to do stupid things. And that's one of the reasons why the buddy system is so essential in scuba diving. All scuba divers know that. And we're not sure of the actual mechanism of that. It may have to do with the increased solubility of nitrogen in fatty tissue, in the lipids of cell walls, I don't know. But inert gas narcosis is important, very important for divers to recognize it. And as I say, the fact that you've got somebody diving with you is very important, but it's important to be aware of the dangers of inert gas narcosis. Sometimes people will dive not with air, but in their scuba equipment, but with oxygen. And that is valuable because if you use oxygen in your equipment and you have a CO2 absorber that's removing the CO2, then using your scuba equipment, you can swim around and not leave any telltale bubbles, because the normal scuba diver is exhaling bubbles of air all the time and they come up on the surface. But suppose you're somebody who wants to do some mischief under somebody else's boat, and that might be someone in the US Navy SEAL program or something like that, then it's very useful to be able to swim around without leaving telltale bubbles. Now that is potentially a dangerous thing to do, because it turns out that oxygen at high pressure tends to cause convulsions, and there may be some premonitory symptoms, but sometimes the convulsions will come on unexpectedly, and of course if you have a convulsion underwater, you're very likely to drown. So it's a potentially dangerous thing to do, and in general scuba divers, amateur scuba divers, don't use this type of equipment, although I'm told it may be available, but it's a relatively dangerous thing to do. And no doubt the Navy divers, the SEAL program people have all sorts of ways of testing people whether how liable they are to develop these problems, but CNS toxicity on the central nervous system is very important. The actual mechanisms of that I think are still being worked out. And while we're on the subject of pulmonary toxicity, let me mention another very important situation where oxygen can be toxic. You know, normally in medicine, pulmonary medicine, we're always trying to increase the level of oxygen in the lung and the arterial blood, but there are situations where the oxygen is actually toxic. And one of these tends to occur in the intensive care unit, where patients with very severe lung disease are being treated, and often their arterial PO2 values are so low that the attending physician is desperate to try and raise the arterial PO2 by raising the inspired oxygen concentration. These patients are on ventilators. There's an endotracheal tube in the trachea, and so the physician has complete control over the inspired gas mixture, and it's very tempting to give these patients a high concentration of oxygen. It turns out, though, that if you give too high a concentration over too long a period, you damage the lung tissue. Probably it's the pulmonary endothelial cells that are initially damaged, but you can cause severe damage to the lung through oxygen toxicity. And a rule of thumb, which I certainly wouldn't, other people know far more about it than I do, but it's often said that if you give more than 50% oxygen for 2 days, then you're in danger of damaging the lung. So pulmonary oxygen toxicity is another problem which we ought to be aware of. It's not related to the CNS toxicity that I talked about before, but it's important particularly in the intensive care environment, and anybody who works there will be very much aware of it. Finally, let's say a word or two about hyperbaric oxygen therapy. I mentioned that a number of facilities now have hyperbaric chambers where you can put somebody and increase the pressure, and that's useful in the treatment of decompression sickness, very important in the treatment of bends. But it's used, hyperbaric oxygen therapy is used for other things as well, and one of the reasons for that is shown on this slide here. Suppose we put somebody in a hyperbaric chamber and we expose them to 3 atmospheres. Okay, we increase the pressure by 2 atmospheres, so they're at 3 atmospheres, and therefore the barometric pressure is 3 times 760 millimeters of mercury. Well, under those conditions, the alveolar PO2 and perhaps the arterial PO2 can exceed 2,000 millimeters of mercury. Very high value. Well, you recall that the solubility of oxygen is 0.003 mils of oxygen per deciliter per millimeter of mercury. And you can see then that if you increase the pressure to 2,000, the dissolved oxygen, the oxygen dissolved, not attached to hemoglobin, is 6 mils per deciliter. So it's an enormous concentration of oxygen just in solution. This actually exceeds the normal arterial venous difference for oxygen. So in principle, you could treat a patient like this who had no red blood cells at all. You could maintain his oxygenation. And so this kind of therapy is used for patients who have a great reduction in the oxygen carrying capacity of their blood. For example, with carbon monoxide poisoning. Carbon monoxide poisoning is not an uncommon event. It often occurs with a house fire. If there's a fire in a house, people are rescued from the burning house, but they've often got a big load of carbon monoxide on board. They've been taken to the emergency room and put in a hyperbaric chamber because the dissolved oxygen then will be extremely useful. Also useful in an anemic crisis. Some patients have very, very low levels of hemoglobin in their blood. Patients, for example, with pernicious anemia, it's a disease where the anemia comes on gradually and maybe the patient's not particularly aware of it, but you can get very low levels with that. Or you can have anemic crises in other diseases where the red cell concentration falls. Hyperbaric chamber is also useful for treating patients who have anaerobic infections. Gas gangrene, for example, is an infection where sometimes treating it with a high level of oxygen is valuable. So those are reasons why hyperbaric therapy is valuable. It went through a period when people wondered if it really was worth putting in a hyperbaric chamber, but now I think its value is appreciated, and it's certainly, you'll find hyperbaric facilities in all big medical facilities. Okay, that's all I'm going to say about diving. A very interesting situation, and of course one of the big stresses for respiration. And now I'm going to conclude by talking about spaceflight. Now, spaceflight, of course, is pretty exotic, and not too many people out there are going to be astronauts. Perhaps some of you will, but there won't be too many, particularly at the present time, because things are a bit slow in the space business. But spaceflight is a very interesting area, and we were lucky enough to become involved with the space program. And the reason why we became involved was that we were very aware of the effects of gravity on the lung. And I've talked about all these in the previous sessions, and just let's have a quick look at them again. The apex of the normal upright human lung has a very low blood flow. In fact, some measurements show that there's virtually no blood flow at all if you're really resting in the upright position, seated in the upright position. So the blood flow has a very low blood flow. The apex has a very low blood flow. It also has a lower ventilation than the base of the lung, but the differences of ventilation, you remember, is not as great as the differences for blood flow. So that means that the top of the lung has a high ventilation perfusion ratio. And that means that the PO2 is high there and the PCO2 is low. And you may remember that we pointed out that one of the interesting clinical consequences of the high PO2 at the apex is that the tubercle bacillus, that's where the adult tends to develop tuberculosis, because the bacillus thrives better at a PO2 of 130 than a PO2 of 90 at the bottom of the lung. And there are other differences too, caused by these regional differences of gas exchange. In addition to that, the lung is distorted by its own weight, like a slinky spring, or if you prefer, the expanding pressure, the intrapleural pressure, is less negative at the bottom of the lung than the top. They're really statements, similar statements really, about what's expanding the lung. And so at the top of the lung, you tend to have large alveoli, larger than at the bottom. You tend to have a high transpulmonary pressure. In other words, the difference between alveolar and intrapleural pressure is greater at the top of the lung than the bottom. And you've got large mechanical stresses on the alveoli. And I think that is probably the reason why a type of emphysema called centriacinar emphysema essentially always occurs first at the top of the lung and then moves down the lung. And that, I believe, is because all regions of the lung tend to get pollutants deposited in them, but the lung fails first, the alveolar walls fail first, where the lung is stressed most, and that's the apex. And there's also a disease known as spontaneous pneumothorax, which people who are medical students, they're the right age to develop this particular disease, and it's caused by a defect, a popping of a part of the lung, a break in part of the lung tissue, almost always near the apex. And again, the reason for that, I believe, is because the stresses there are high. And another result of this, the effects of gravity, is you can get airway closure at the bottom of the lung. In normal subjects, this occurs at residual volume, but in older people, apparently normal people, you can get airway closure at somewhat higher lung volumes, and even in some people probably at functional residual capacity. And if that occurs, of course, you've got intermittent ventilation of that region of the lung. And that also tends to occur in chronic obstructive pulmonary disease. So there are lots of effects of gravity on the lung, and we wondered what would happen in the absence of gravity, and we were lucky enough to be able to make some experiments on the Space Lab. Now, Space Lab was taken up by the shuttle, and we've all seen these beautiful photographs of the shuttle launch with its solid rocket boosters doing their thing. I never cease to get a thrill out of looking at that. What an extraordinary thing it is that you can do that. Once you get into orbit, the Space Lab is shown here. Space Lab is in the bay of the shuttle, as you can see, and it consists of a cylindrical laboratory. It's approached through a tunnel from the flight deck here, and it's a laboratory where conditions are essentially normal barometric pressure, normal inspired gas concentration, oxygen is 21%, normal temperature, humidity. The only thing that's different is, essentially the only thing that's different is that it's weightless, that there's what NASA calls microgravity. So it's a very, very useful way of carrying out experiments, and here's a picture of the Space Lab under 1G conditions. This is at the Johnson Space Center in Houston, and you can see the astronauts here working on these racks all around. It's a very efficient way, an enormous amount of equipment in here, and a very efficient way of doing experiments. On orbit, it looks a bit messy, as you can see here, and here are various astronauts doing important things. Another one, I think, is acting the goat here, but you can see it's a busy environment. So we were able to do a study of pulmonary function in microgravity, and I'll just mention that very briefly. We had a package of 9 tests, many of them similar to tests I've been talking about during this series of lectures. They're the sort of tests you do in the normal pulmonary function laboratory. But we were able to arrange for these tests to be done in just over an hour, and furthermore, that a crew member could perform the tests on himself or herself. That's a very valuable feature from NASA's point of view, because crew time is at a premium on a flight. They're very worried about crew time. The data were available on the ground in real time. We were at the Johnson Space Center, and we could see the data coming down on screens. In fact, it was just as the experiment was being done in the room next door, and we got a reasonably comprehensive assessment of pulmonary function, most of it relatively simple tests, but nevertheless we learned a great deal about pulmonary function. Here's a photograph of one of the astronauts carrying out the experiment. You can see that she has a valve box here. There are 2 valves, one on each side. She's being prompted by a screen here to do all the right things, but she knows exactly what to do. She's done this experiment hundreds of times, and she's very familiar with it. And she goes through a series of maneuvers, different lung volumes, breathing different gases, and so on, and got a great deal of information about the way the lung works. Here's an example of one of the tests we did. We measured the diffusing capacity for carbon monoxide. Remember, we talked about that during the session on diffusion. And let's see, this axis shows the values as compared with pre-flight in the standing position. Pre-flight standing here, pre-flight supine here. This is before the flight, okay? And then we have a flight. In this case, this was, I think, SLS-1. The flight was about 9 or 10 days of microgravity, as you can see. And when the crew member went into microgravity, there was an immediate rise in diffusing capacity, and that was maintained during the flight. And incidentally, we were able, in this particular subject, to measure the diffusing capacity, both breathing air and with a high concentration of oxygen in the lungs, and that allowed us to separate out the diffusing capacity of the membrane and the volume of blood in the pulmonary capillaries, and both of them increased. And you can see that when the subject came back down to Earth again, there was an immediate return to essentially the normal values that were seen before. So this is an example of the change in diffusing capacity. Now, all sorts of measurements have been made in space, and it's not appropriate to talk about them here, but I'll just summarize some of the most important findings. As I said, there's an increase in pulmonary capillary blood volume. Why is that? It's because under normal one-gravity conditions, blood tends to pool in the dependent parts of the body, the legs, as I'm standing here. Blood tends to pool there. When you go into microgravity, there's no pooling of blood caused by gravity. Blood tends to come back into the upper part of the body, and thoracic blood volume increases, pulmonary capillary blood volume increases. There are other signs of that. If you look at astronauts on orbit, a photograph, you'll often see that they've got puffy eyes, and that's because the interstitial pressure is increased in the upper part of the body because of this return of blood from the dependent regions. So an increase in pulmonary capillary blood volume, an increased diffusing capacity, as I showed. We found an increased cardiac output. We were using nitrous oxide rebreathing to measure cardiac output and stroke volume, particularly in the early part of the mission. The distribution of blood flow and ventilation became more uniform, as you might expect, because gravity causes regional inequality, although the changes in ventilation in particular were not dramatic, and there is still some uneven distribution even in weightlessness, because you can't expect the lung to have evolved so that every gas exchanging unit has exactly the same ventilation and blood flow. That's not the case. So there is some maldistribution or uneven distribution in weightlessness. The functional residual capacity was between the upright and supine measurements at 1G. And that's because in the upright position, the diaphragm is pulled down by the weight of the abdominal contents. In the supine position, the diaphragm is pushed up by the weight of the abdominal contents, and in microgravity, it's halfway in between. And that was predicted, incidentally, by one of the physiologists many years ago. A very interesting finding is that residual volume was decreased. I say interesting because it's very difficult usually to change residual volume, and we think that has to do, and I don't have time to go into it in detail, has to do with the fact that all the alveoli presumably are at the same size, and therefore all of them can go down to a low volume when you exhale as far as you can. There are also changes in the deposition of aerosol. These weren't measured in Space Lab. These were measured in a parabolic aircraft flight where you get short periods of weightlessness. But it's not surprising that the deposition of aerosol has changed, because remember, one of the factors in the deposition of aerosol is sedimentation, which is a gravity-determined factor. So here's the carry-home message here. Pulmonary function in microgravity, we found that the Overall gas exchange of the lung is not changed. You may say, well, I'm not surprised at that because it's the tissues that are responsible for the oxygen uptake and CO2 output, and certainly they're not changed. The alveolar PO2 and PCO2 were unchanged in microgravity, and in fact, there was no significant impairment of lung function during 2 weeks of gravity. And so I think one can say that relatively long-term exposure to microgravity is not going to affect the function of the lung during microgravity. Even more significant perhaps was that we were able to do some measurements on astronauts that had been on the International Space Station for up to 6 months. And we were able to show that when they returned to sea level, to normal gravity, lung function within a few days returned to its pre-flight conditions. That, by the way, is not the case with muscle changes or bone changes in microgravity. They tend to persist when people return. But as far as lung function is concerned, it looks as though there's no serious problem during spaceflight, and that when you return from spaceflight, lung function returns to normal. And of course, that's what NASA wants to know. What NASA wants to know whether lung function is going to be one of the showstoppers during a flight to Mars, for example, and I think that's very unlikely. Of course, we want to help NASA, but at the same time, we want to use microgravity as a mechanism of clarifying what happens to the lung under 1G conditions. So that's all I'm going to say about the lung under stress. Let's just summarize some of the points we've made. The lung has enormous reserves of gas exchange, and exercise, of course, is one way of stressing these reserves. And as I said, the oxygen consumption can increase 10-fold, even 20-fold during exercise in fit people. So exercise is an important stressor of lung function. I mentioned that ventilation increases linearly with oxygen consumption up to a point where sometimes you can see a sharp break and ventilation increases more rapidly. That's sometimes called the anaerobic threshold, or perhaps a more politically correct term now is the ventilation threshold, and is thought to be due to the increased formation of lactate. Incidentally, I should have pointed out, and it was shown on the slide, small amounts of lactate occur at low levels of exercise as well. So don't think that there's no lactate below the anaerobic threshold. There is, but there's an increase, and that increases ventilation because the lactic acid, the hydrogen ion concentration, stimulates the peripheral chemoreceptors. We talked about high altitude, and of course the reason why that's important is that the barometric pressure decreases, and therefore the PO2 decreases. The most important feature of acclimatization to high altitude is hyperventilation. We mentioned that there is also polycythemia, but for lowlanders going to high altitude, this is normally not a terribly useful thing because it takes so long to develop. Although I should have perhaps added that when you go to high altitude, the first couple of days you often have an increased red cell concentration, but that's not due to increased red cells. That's because the plasma volume is decreased by the dehydration of high altitude. I briefly mentioned high altitude pulmonary edema, which is a disadvantage of the changes that occur at high altitude. It's related to the hypoxic pulmonary vasoconstriction and the fact that that's uneven, and therefore some capillaries are damaged. We went into the physiological changes during diving, including decompression sickness, its treatment and prevention. We said a bit about heliox breathing, saturation diving, inert gas narcosis, which is caused by nitrogen. The scuba divers out there will be aware of it. The central nervous system toxicity resulting from breathing oxygen at high pressures, which is a potential problem if a scuba diver tries to do this. We mentioned oxygen toxicity in the intensive care environment and said a word or two about hyperbaric oxygen therapy. And finally, pulmonary function in space, a somewhat exotic area, but of interest, because what it does is tells us about the mechanisms of the changes that occur under 1G conditions. So it's important from that point of view, and also it's important for NASA to know that astronauts can go to the moon and probably not have serious problems with pulmonary function. So that's all I'm going to say about respiration under stress, and I look forward to seeing you at the final session where we'll be talking about respiration at the limit. So bye for now.